The sudden death of a young athlete is a tragic and highly emotional event that has a lasting impact on friends, families, peers, and the wider lay and medical communities. Although the incidence of sudden cardiac death in young athletes is relatively low, estimated at 1 in 50,000, hereditary and congenital abnormalities of the heart are the leading cause of non-accidental death in young athletes. Prevention of these tragedies has therefore become an important focus of the medical community, either through primary prevention and screening or secondary prevention with effective cardiopulmonary resuscitation. Although they differ in the protocol, both the American Heart Association and the European Society of Cardiology recommend pre-participation screening of young athletes on the premise that the majority of conditions implicated in young sudden cardiac death can be detected during life, and that interventions are available, and potentially acceptable interventions as that, to reduce the risk of sudden death in those identified with disease. The American Heart Association recommends screening with history and physical examination only, whereas the European Society of Cardiology advocate the routine inclusion of the 12-lead ECG. The American Heart Association model is cheap and pragmatic, but lacks sensitivity because over 80% of athletes that die are asymptomatic. Whether early detection of disease translates to life saved is a contentious issue. The most persuasive evidence that early detection of disease has a positive impact on the prognosis in individuals identified with disease comes from a study in Italy, a country where screening of athletes is mandatory by law. In this study, the investigators reported an 89% reduction in the incidence of sudden cardiac death in athletes screened with ECG over a 25-year period. Despite the success of the ECG screening program in Italy, one of the concerns of the ECG as a screening test relates to the high false positive rate. You've already heard this morning, but on occasion, the electrical changes in athletes can overlap with the electrical patterns seen in individuals with cardiac disease. Whilst one cannot place a monetary value on a life saved, the workload and cost of further investigations required to confirm or refute the diagnosis of cardiac disease is a cause for concern, and certainly is cited as one of the reasons not to screen young athletes. This limitation has led to the developments of ECG interpretation criteria in the last decade to assist physicians involved in the cardiovascular evaluation of young athletes. In 2010, the European Society of Cardiology published their recommendations. They differentiated the physiological ECG changes, the so-called Group 1 or training-related changes, from the Group 2 training-unrelated changes that may be pathological and may warrant further investigations. In 2013, the Seattle criteria were published and made two important amendments to the ESC document. Firstly, they incorporated the impact of ethnicity on the athlete's ECG, specifically the recognition that T-wave inversions in the anterior leads may be a normal phenomenon in Afro-Caribbean athletes. Secondly, they designated less conservative criteria for abnormal QT intervals. And in 2014, research undertaken through Cardiac Risk in the Young resulted in the publication of the refined ECG criteria. These criteria provided a list of additional electrical anomalies in the yellow circle, which, when present in isolation, are considered benign and do not warrant further investigations. Modification of the ECG interpretation criteria have significantly reduced the false positive rate and improved specificity. Importantly, they have not compromised the sensitivity to detect serious cardiac disease. Whether such modification has any impact on cost has previously never been investigated. In collaboration with the London School of Economics, we therefore undertook this study investigating the cost implications of using different ECG criteria for screening young athletes in the United Kingdom, which was published in the Journal of American College of Cardiology in August this year. Over a 4-year period, nearly 5,000 young athletes who were participating at national and international level were screened nationwide by Cardiac Risk in the Young. These athletes were undergoing evaluation for the first time as a mandatory requirement of their sporting organization. The majority were male and Caucasian, although 9% of the cohort were Afro-Caribbean. In total, 26 different sporting disciplines were represented. All athletes underwent screening with history, physical examination, and ECG which was interpreted with the 2010 ESC recommendations. In our cohort, 2% of the athletes had an abnormal history and physical examination, and 22% exhibited an abnormal ECG. Athletes with abnormal screening tests underwent further investigations at hospitals in their geographic vicinity and were followed up prospectively for a period of 2 years. We calculated the workload and cost implications based on the United Kingdom National Health Service tariffs. Furthermore, we evaluated the impact of the Seattle and refined ECG criteria on workload and cost. In this study, 11% of athletes underwent echocardiography, 1.7% underwent an exercise test, 1.2% underwent a Holter monitor, 1.2% underwent a cardiac MRI scan, and 0.4% underwent other tests to confirm or refute the diagnosis of cardiac disease. 15 athletes were diagnosed with cardiac conditions implicated in young sudden cardiac death, all on the basis of an abnormal ECG. The overall cost for the evaluation was just over $500,000, equating to $110 per athlete screened and just under $36,000 per serious diagnosis identified. As expected, the Seattle and refined criteria reduced the proportion of abnormal ECGs to under 5%. As a consequence, the refined criteria would have reduced the number of echocardiograms by 50%, exercise tests by 12%, Holter monitors by 8%, and cardiac MRI scans by 18%. Importantly, all 15 athletes who were diagnosed with serious disease would have been detected with the refined criteria, suggesting no compromise in sensitivity. As a consequence of the reduced workload, the refined criteria reduced the cost per athlete screen to $87 and the cost per serious diagnosis to just over $28,500, equating to a 21% cost reduction. These savings from the refined criteria would comfortably allow affordability to screen an additional 2,120 athletes or purchase nearly 100 AEDs. The impact of this ECG modification on cost effectiveness would require the long-term follow-up of these athletes. There have been other studies which have estimated the cost effectiveness of ECG screening with very variable results. As you can see, some studies have reported that the cost per life year saved from ECG screening is $44,000, which is acceptable. However, other studies have demonstrated this to be above $14 million. The reasons for this variation are essentially related to the methodology of the study, which vary from study to study. In particular, there is inconsistency when considering the definition of an athlete. There is variation in the disease prevalence used in the studies, and possibly the most important, there is variation in the cost parameters used for these cost-effective studies. There have been other methods suggested that may potentially reduce the cost of cardiac screening in athletes. A recent study published in the Canadian Journal of Cardiology investigated the impact of an evidence-based modified health questionnaire and found that this reduced the false positive rate of screening compared to the traditional American Heart Association questionnaire, which also resulted in cost savings. The value of the physical examination in screening has also been questioned. A recent meta-analysis published in the BMJ concluded that physical examination is poorly practiced, understood, and trusted in many contemporary healthcare settings. It is possible that this does contribute to increased costs. Finally, this is unpublished work from our institute, where we found that inter-observer agreement for further investigations amongst cardiologists following ECG interpretation ranges from fair to moderate, even in experienced cardiologists who are used to screening young athletes. This suggests that future ECG interpretation guidelines should provide a list of minimum investigations pertaining to specific electrical anomalies. This may potentially reduce variation in clinical practice and therefore improve efficiency and potentially reduce cost. So to conclude, ladies and gentlemen, as screening physicians, we champion the cardiovascular safety of our athletes at all costs. However, we have to have responsibilities for the financial implications of our practice. Modification of ECG interpretation criteria are associated with a 21% reduction in the cost to screen young athletes. These findings will be welcomed by organizations that mandate ECG screening for their athletes and may allow for less financially endowed sporting organizations to afford to screen their athletes. There are persuasive arguments that these resources would be better off served in improving facilities for secondary prevention with cardiopulmonary resuscitation and AEDs, which have proven efficacy in saving lives. However, as you've already heard in one of the earlier lectures, 40% of sudden cardiac death in athletes occur in sleep, and these deaths are unlikely to be prevented by early access to a defibrillator. This highlights the importance of effective primary prevention and screening to identify those athletes who may be at risk of sudden cardiac death.